Okay, at least for now we don't have any problems because Johannes Lehtonen, he will present in English. He had been for more than 20 years professor of psychiatry at the University of Kuopio in Finland. He is a clinical neurophysiologist, psychiatrist and psychoanalyst, and he has very long experience in this very difficult interdisciplinary research, bringing together on the one hand side research on the mind, clinical mind research, and on the other hand neuroscience. So he has many studies going on with brain imaging in the field of depression, for instance. Also a strong interest in the psychophysiology, for instance in mother-infant relations, interactions, or in breastfeeding. Today he is going to present, and in the program it is a short title, on serotonin and psychotherapy. But as you can see on the PowerPoints, it is a longer title. It was changed to Serotonin, Vital Affects and Psychotherapy, Theoretical Background and Preliminary Findings. Please.
Först vill jag säga på svenska, jag skulle ha velat att prata svenska, men det är så många svåra begrepp som jag inte känner till hur det låter på svenska, så jag kan inte ge föredraget på svenska, men jag känner ändå mig själv lite grann hemma också i Sverige och skulle därför också velat prata svenska. Well, in any case, it's better to use this. This presentation begins with some theoretical remarks, and then I proceed to try and conceptualize the primitive layer of the mind, which is very close to our bodily functions and bodily feelings. And thereafter I proceed to tell some reviewing remarks on research on neurobiological dimensions of psychotherapy, and then I proceed to our own experiences of similar efforts. I also want to convey regards from my Finnish colleagues, because I feel it is such a good, nice and important effort to create a network between Nordic countries and maybe even more widely internationally on this slowly developing area of psychotherapy research. We have in the within the Finnish Psychoanalytical Society a research consortium with the aim to bring together people with research interest in dynamic themes, not only for analysts but also for other people. We have had that for some 4 or 5 years. And then we have annually in Jyväskylä, in the central part of Finland, the University of Jyväskylä arranges annually conferences on psychotherapy research, also has been going on for some 3-4 years now. And now my motto for this talk is, here when psychotherapy and neuroscience meet, a frame for their interaction or a kind of grammar has to be developed. We don't, I mean here that we don't have anything that kind ready there. It has to be created. So we should not have the illusion that there is somebody, or there are some groups or some disciplines who know already how to combine these. It's a new task, and we have to create a frame for this interaction. This question of the relationship between serotonin function in the brain and psychotherapy is obviously part of a more general relationship between the mind and the brain. And we also know very well that this relationship is a very complex one and a disputed area. Is there a real relevance of neurobiology that could be applied to psychotherapy? That's an open question. And is there a relevance the other way around, applying psychotherapeutic knowledge on neurobiological studies and questions? That's also an open question. It has been a great help for me, at least, to distinguish between two different forms of this great philosophical question, the body-mind question. I think it is philosopher John Searle who has made this distinction, and which appears in the literature now quite often by several authors, that we have the hard problem. How is it possible that the material brain can produce the non-material mind? This is a hard problem, and nobody has given any definitive solution to this. That best Francis Crick, the Nobel Prize winner and one of the DNA discoverers, gave his 3 last decades of his life to this question, and nobody else has been able to solve. So we have this hard problem which is unsolved, and we have to be happy with it. But we have the soft problem, and the soft problem asks how, when the mind changes, when we have perceptions, we have affects when we are active or we are asleep. The mind changes, how does the brain change along as the mind changes? Or the vice versa, when we see that the brain state changes, how is the mind following that? And we have plenty of data about these issues, plenty and plenty and plenty. And this soft issue can be approached by various techniques. And I think this is, in a way, relieving, because we can, in this perspective, without any hard feelings or hard problems, study these soft relationships between the mind and the brain, and forget that there is the hard problem which is not solved by these soft issues. So we can work freely, but we are not going to find the final answer. So this approach also, I think, suits quite well to the network creation. When we are creating a network between different disciplines, we cannot rely only on one approach. We have to accept several approaches at the same time and create a network between them. And this type of philosophy, I think, fits relatively well to that kind of effort. Then to the primordial mind, the primitive layer of the mind. Here I almost always go back to Freud's definition of the basic structure of the ego. He says that it is the body ego, But there are other important researchers or philosophers who have said the same thing much earlier than Freud did. For instance, Spinoza's philosophy was based on this principle that the mind is actually an image of the state of the body. And the body-ego forms a basis for constant automatic self-observation. It is not the cognitive self-observation, but the constant monitoring, more or less on a physiological level. And how we get contact with this body-ego monitoring, it is obvious that we get a contact to this layer by trying to be tuned to bodily feelings in ourselves. So the primordial mind monitors the non-verbal state of the body and brain and does this monitoring in the pleasure-pain axis. Again, back to Freud, but also many other researchers, John Huggins Jackson, who is a very well-known neurologist, follow this line. William James' approach, I think, can also be understood in this way. And it is important to see that the bodily sense of being is not, it is a moment-to-moment basis. Our bodily sense of existence changes all the time. It's an ongoing change. So it is not that we have this kind of feeling state and then we have another. It's constantly going. It's part of life, of course. And Damasio calls this level of the mind the background feeling, which is prevalent behind the ordinary cognitive consciousness. But this bodily self-consciousness is not only looking inside, it's open to the outside world via the sensory perceptual channels. So our body and brain functions are embedded in our non-verbal self-image. Then one more theoretical point of view when we have in our mind the question how to relate mind and body. And I like to refer here to Freud's epistemology. I think he said this already earlier, but in his last work, in the Outline of Psychoanalysis, he wrote that to establish psychology on foundation similar to those of any other science, such for instance as physics, what psychoanalysis is, he was explaining it in this way. And he continued, reality will always remain unknowable. We have discovered, referring to psychoanalysis, psychoanalytical technique, technical methods of filling up the gaps in the phenomena of our consciousness, and we make use of those methods just as a physicist makes use of experiment. So he parallels psychoanalysis and physics, which is a little bit astonishing. We are not used to think in such a way. But in this perspective of Freud's epistemology, I think we can quite legitimately study the possible biological changes that may parallel the clinical effects of psychotherapy. So in a way we get back to the soft problem, and we have the permission to study. We don't have to stuck to is it possible to go from one to the other. Just do it. And from epistemology to clinical reality. So what we factually do in psychotherapy, we need concepts that are specific to psychotherapy, psychoanalysis. We need theories and methods which are specific to psychotherapy. Like the natural sciences need their own theories and methods. And we know very well that natural sciences stand on empirical verification, and psychotherapy, the substance of psychotherapy, stands on subjective reality, psychological interaction, and hermeneutics, interpreting the psychological contents. And now, how can we now place the primitive layer of the mind, the body ego layer, or the background feeling layer of Damasio to this scenery? And as I tried shortly explain that the body ego feeling, it's not the feeling states, the bodily feeling states we have. It's non-verbal, and it's in a way pre-psychological. So for the body ego feeling to acquire a personal character, a personal human face, so to say, or a personal identity, the body feeling has to have an owner. The child develops at a certain stage, maybe roughly at the age of 3 months, 2, 3, 4 months, I can't say precisely, a personal identity, the personal smile and the psychomotor coordination and other features which tell that the small child knows to whom respond, and that the child does it by his or her own intention. The child begins to own his or her own state of the primitive psychophysiological mind. So this is a step from the psychophysiological bodily self towards the psychological identity, the first step. And in psychotherapy, I think we are dealing with this borderland also when we confront our patients' bodily symptoms and feelings, and when there is a possibility to give words and personal ownership to those symptoms or feelings. So when we come to this true psychological level of working based on personal identity, fragile or strong, but in any case on personal identity, we also come to the level where the couple, the psychotherapeutic couple, is working on a truly psychological level. And we can say that the psychotherapeutic couple has a clinical ontological autonomy in relation to the bodily self. So the relationship in psychotherapy is created on basis of what the patient brings to the work and what the therapist brings there. It's not created on basis of some neuroscientific data. The work in the consulting room is not based on data from neuroscience. But the possible neurobiological effects of psychotherapy, if they occur, we can say that they represent an unintentional biological benefit, or a kind of added value, or you could also say a kind of positive biological side effect. I mean, the work is going on a psychological level, but behind there something happens also on the biological level. So this is really the basic philosophy of doing biological research on the effects of psychotherapy. This was implied in Freud's formulation. In 1913, he wrote a pretty long article which has not been paid very much attention, the claims of psychoanalysis to scientific interest. And we said that we have found it necessary to hold aloof from biological considerations during our psychoanalytic work and to refrain from using them for heuristic purposes. not trying to explain psychology by biology, so that we may not be misled on our impartial judgment of the psychoanalytic facts before us. And then he continues, but after we have completed our psychoanalytic work, we shall have to find a point of contact with biology. And we may rightly feel glad if that contact is already assured at one important point or another. So the field remains open even though we have this clinical ontological autonomy. Erik Kandel, another renowned neurobiologist and Nobel Prize winner, wrote already in 1979, when he was not so famous yet, a very influential article titled Psychotherapy and the Single Synapse. And there he says that when it comes to mental function, after having explained the synaptic mechanism in powerful detail, then he says that when it comes to mental function, however, biologists are badly in need of guidance. It is here that psychiatry, in which he included psychoanalysis, psychotherapy, it is here that psychiatry and psychotherapy is needed as guide and tutor of its antidiscipline. Kandel says that biology is antidiscipline of psychotherapy, and the other way around, of course. Psychotherapy is an antidiscipline of biology. So that is, we as therapists are needed as a guide and tutor for neurobiologists. And we can make a particularly valuable contribution to neurobiology. And psychiatry and psychology can illuminate and define for biology the mental functions that need to be studied if we were to have a meaningful and sophisticated understanding of the biology of the human mind. So I think what Kandel says here is really, again, the principle of clinical ontological autonomy of psychotherapy. So it's not a reductive attempt that reduce psychotherapy biology or explain biology completely by psychodynamics. So it's a fruitful interaction that is needed. One more detail from Kandel in an article a little bit more than 10 years ago. He says that he writes the new Bible for psychiatry. This article was the new intellectual framework for psychiatry, and starts all mind processes are based on neural activity in the brain, and then many things and wonderful details. And then he said that the effects of psychotherapy should be observable in changes in brain function. And this, he says, is based on the fact that any significant learning experience can regulate the activity of the DNA in nerve cells. These significant experiences do not change the DNA code, but they affect whether the code is active or not. So the opposition between the laws of biochemistry and the dynamic function of the mind, this opposition vanishes in this perspective. I don't know if I've understood it correctly, but this is how I think it should be understood. And now to I have to watch 15 more minutes. Now to the brain imaging studies that have been done on outcome of psychotherapy. We have today more than a dozen studies that have been published in peer-reviewed journals demonstrating changes in brain activity as a function of psychotherapy. there are at least 3 reviews: Rothman in Psychological Medicine, Linden in Molecular Psychotherapy Journal, and Beauregard in the Nordic Journal of Psychiatry on these studies. And we know already that psychotherapy can reduce the pathological increase or the pathological decrease of brain activity in various psychiatric conditions like depression, phobias, and obsessive-compulsive disorders. And the psychotherapeutic techniques that have been used have mainly been CBT, also interpersonal psychotherapy, and only very few, actually, only those that come from Finland are based on dynamic psychotherapy. And these studies can be summarized that the effects of psychotherapy on brain have been shown to be partly similar with the effects of psychopharmacological treatment, and partly also different. So there seem to be specific effects on the brain by psychotherapy that are not obtained by pharmacological treatment. Here is a list of the almost 10 first studies. There are more have appeared after making this picture. Then I go to in a more detailed way to the serotonin function. The main corpus of the studies that have been published measure the brain activity of various brain regions and the activity differences between various brain regions that occur during psychotherapy. These studies mainly do not focus on biochemical events or on synaptic events. And as we have done research on serotonin function in connection of psychotherapy, we think that there is a particular interest in studying how the serotonin function may change or may not change in psychotherapy, because it enables monitoring the non-verbal effects of the primal consciousness, or the body ego level, in relation to neurobiology of serotonin. And it also enables comparison between the effects of psychotherapy and psychopharmacology. Serotonin function, the core nuclei are very deep in the brain stem, the so-called Rafe nuclei, but as you can see, the pathways spread all over the brain. So serotonin is not a limited function. When there is a true change in serotonin synaptic, in the system of serotonin synapses, it can have an effect practically on all over of the brain. This is expressed by Antonio Damasio this way: serotonin is part of an exceedingly complicated mechanism which operates at the level of molecules, synapses, local circuits and systems in the brain, and in which sociocultural factors, past and present, also intervene powerfully. So it's far from a reductive approach, what he has in this respect. And now I try to connect what I said before about the body ego, the primal primitive consciousness close to the body functions, and the serotonin function. These serotonin nuclei, these deep in the brainstem I just showed, they participate in the regulation of the all-over activity level of the brain, such as the well-being, sense of well-being, our arousal, our sleep-wake cycle, also influencing on the eating cycle. And the serotonin is also involved in the regulation of mental pain and the endurance of feelings of frustration and anger. If the serotonin function is poor, the subject is not able to feel frustration and anger. So there is a need to have a good enough level of serotonin function for our affects to work normally. So serotonin therefore also plays a major part in the symptoms of depression, as is very well known. So we can summarize that well-functioning serotonin synapses enable feeling of emotions. It is the subjective sense of having effects. And when there is a reduction of available serotonin, that is followed by the freezing of affects. We lose, affects are stopped or freezed down. So this freezing of painful affects is of course a mechanism of defense. So we can say that serotonin reduction in the brain is a kind of biological mechanism of defense, of trying to hamper or stop painful effects. And vice versa, when the serotonin function is restored, if it has been reduced, the effects are brought back. And if we have a patient with depressive symptoms, when the serotonin function returns, the depressive feelings are also activated. So this is the paradox of getting better. More pain, more bad feelings, even though it may be a question of revitalization of the effects at the body-ego level. So then shortly to our own studies, here you can see that there is patients with major depression and healthy controls. The serotonin, to be precise now, I have been talking pretty loosely about the serotonin function, etc. It's a complicated presynaptic, synaptic and postsynaptic event with transporters and many different receptors. So excuse me if you have been thinking that what I'm talking, but it's nevertheless a system. And this, what we have been measuring here is the serotonin transport. It's a presynaptic. It's that part of serotonin function which produces serotonin to the synapse, so that there is enough available serotonin in the synapse. And in healthy patients, they have a higher level of serotonin transporters compared to patients with major depression. So we have a valid problem here, and you can see that this is the RAFE, and the white spot represents the transporter you have to believe. And here you have a depressed patient, hardly any white spot, clearly reduced serotonin level. And this can be measured quantitatively and has to be. So we first had a male depressed subjects, a single case with a control case with a similar symptoms, another young male patient. And the first one was motivated for 1 year of psychotherapy once a week, and the comparison patient was not motivated. Both were investigated at the beginning of the observation and 1 year later. And the index patient showed astonishing normalization of the serotonin reduction. It returned to normal level. So we were struck about this and wanted to know more. Then we had another female patient with anxiety and depression, also reduced serotonin function. At the beginning, she was treated for 2 years, but the measurements were done after the first year. She was still with her symptoms, no symptomatic recovery after 1 year of treatment, but the serotonin level had already normalized. And then 6 months later, also the clinical picture normalized. So we had an indication that there may be not a direct correlation between the symptoms and the serotonin level, and the serotonin normalization may become first and the clinical recovery only later on. But this is just cases. Then we collected a naturalistic sample of depressed outpatient subjects in our clinic, 18 patients. They had a dynamically oriented supportive psychotherapy by the nurses and psychologists and doctors working in the clinic. And we found that there is a very vague correlation, and we did not understand this difference. Here is the improvement of Hamilton score. There are patients who improve in Hamilton score and show increase in serotonin function. But there are also patients improving clinically, but not improving in the serotonin function, even going down. It was just a variation, we thought. We didn't understand that there may be two different groups of patients. Then I collected a further series of patients with atypical depression, 8 patients, and classical major depression, 11 patients. They had also 1 year of psychotherapy twice a week. Both groups showed clinical improvement, but serotonin transporter level was recovered only in those with atypical symptoms, but not in those with classical major depression symptoms. So you can see that the Hamilton score in major depression, beginning relatively high, reduces to half, and the atypical scores do not change in major depression because they don't have these atypical signs, and serotonin level rather reduces than improves in patients with classical symptoms. But in patients with atypical symptoms, Hamilton score reduces pretty well, atypical score reduces very well, and serotonin function improves significantly. So we seem to have two different kinds of responses. We don't have a precise explanation to this, but my hypothesis is that in ordinary major depression, there is the internal serotonin freezing effect, which produces the painful effects, and the patient becomes better clinically, but she uses her own internal biological functions to maintain the state. And those with atypical symptoms, they have a different mechanism. Their serotonin function is relieved. They also can get more symptoms in the beginning, but then they improve both clinically and in the atypical symptoms. And here is that in quantitative terms. In the beginning, the non-atypicals have somewhat higher serotonin level. The classical patients have somewhat higher serotonin level, atypicals are more reduced, and after treatment, atypicals change upwards, and non-classical patients rather go down. So I pass the limitations of our study, which are obvious, the small number of patients, etc. We have also strengths. No psychopharmacological treatment was used in these patients. And we had healthy controls who showed that the CERT level was unchanged almost exactly in 1 year follow-up in healthy patients. So this variation in patients is not due to the method we have been using. So these are the preliminary findings. I could stop here, the time is running out, but shortly the conclusions. Serotonin is relevant for the biology of normal human interaction. Psychotherapy, like any affectively significant interaction, may give rise to physiological changes in serotonin or in other physiological functions. It's a question of general vitality, the bodily feelings, but it's also a question of conflicts. I cannot go more in detail how the conflict concept can be posed in this scenery of brain function. And I want to underline that the decrease in serotonin is not necessarily irreversible, because our idea of serotonin in depression is so much contaminated by the idea that it's only a pharmacological question. It's part of our normal psychophysiology, not only drugs. There is now a study by my colleague Hasse Carlson from Turku, Åbo, who has done a PET study and shown that serotonin receptors, I have been talking presynaptic function, the receptors are on the postsynaptic side of the synapse. He has shown with his group that the postsynaptic receptors of serotonin may increase in dynamic psychotherapy, which does not happen in his study by using psychopharmacological treatment. We could not use a psychopharmacological control group because our method was such that the drugs would have obliterated this method of measuring. And then finally to the ontological clinical autonomy, these biological dimensions of psychotherapy do not require special attention in our clinical work. Our main matter is to keep in contact with the effects of the patient and of the therapist, of course. And the psychotherapy, during the psychotherapeutic interaction, physiology automatically takes care of itself. So we may leave it doing that. And when we are tuned to the effects on the bodily level, it is also so that we are tuned to very intimacy of the patient, the intimacy of the patient's mental life, and also tuned to the instincts of the patient, so the core issue in dynamic psychotherapy. So thank you very much.
Thank you very much, Johannes, for this very stimulating presentation. I think we should take a couple of minutes for some questions before we start with the lunch break. You want?
Perhaps I can speak up. I think you're making a very interesting distinction between the soft and the hard problem, which is very important. With the soft problem, it's very convincing the way you reason that the way psychotherapy can affect brain in different ways. But the other way around, I mean, the hard problem is very treacherous and you can easily come to false conclusions. And quite recently there was an article in the Swedish Medical Journal depicting the problem of serotonin and depression. And it was said that there is no evidence that there is a lack of serotonin in depression. There's no such direct contact, and that is very difficult. And the drug industry is making a great thing of this, that low serotonin, you have to have the SSRI drugs, I mean the serotonin, selective serotonin reuptake inhibitors, and which is a false conclusion, which is a false marketing of the drugs, because you don't know whether this is a direct effect or a secondary effect in the long run.
Yeah, I agree with you. There are contradictory reports whether this parameter, that transporter function, is reduced in depressed patients or not. But the majority of the studies have found that it is reduced. But there are studies also showing that it is not reduced. So it can be contested. And serotonin takes two central parts in the debate about the biology of depression. So it's one dimension, and it may not be primary, but we can study it, and it's whether it is a primal evil in serotonin or not. I don't think that it's a primal evil in serotonin. It's more complex, and there are other very important biological functions which we cannot go try and formulate here. But nevertheless, it's interesting to see. It's one part of the psychophysiological health of a human being.
Andre, could you take
in this same article, it was also said that this social could immediately see the effect of increasing it when you had this SSRI, but the effect of it only shows after like 2 or 3 or 4 weeks. So that's quite tricky. What is really effective?
Yes. It's well known that there is this time interval in the drug treatment schedule, and nobody really knows how to explain it. I think one of the major hypotheses now is that there is a factor called the brain-derived nerve growth factor, which is required for new synapses to be formed. And it takes time for this brain-derived nerve growth factor to make its effect. And this might explain the time delay. And serotonin seems to stimulate this nerve growth factor. So there may be a relation between serotonin and this factor. But this is, I have to confess that I am not such an expert in this neurobiology that I can say with full heart that this is the essential, all the essential. There may well be other factors that are not known yet.
No more questions? Then I would say we start the lunch break. Thank you very much again.